I'm just going to start the recording and then I'll hand over to you, Natasha.
Thanks very much, Jenny. I'm Natasha MacDonald. I'm consultant gastroenterologist and physician in HMIS Hospital, and my main and almost the only interest at work is liver disease, and I'm absolutely delighted to be part of this education program for GPs in Lanarkshire, and I would like to talk to you today about the fatty liver disease, which is the commonest liver disease. So it's always a good place to start with something that is very prevalent. I've put my email at the bottom of the title slide. I'm very happy to receive emails with anything liver disease related, whether it's clinical or service related. I can't guarantee I will reply straight away, but I will get back to you. So please get in touch, because we're all working together as a team in Lanarkshire for our patients. So I've just come back from a European liver disease meeting, which was in Milan, and there was a lot of interest and lots of sessions on fatty liver disease. Both clinical research and also involving the industry. So I have made this presentation for you today to share hopefully the most up-to-date evidence and guidelines and pathways to bring us all up to speed, and also a little bit about where we're going next in the next 5 to 10 years, because there will be new developments coming our way. Driven by the clinical need, but also by the commercial interest of the big pharma companies, I suspect, because of the big market that is available to them around the world, and that's just how we are, how things are at present. So at the end of this bite-sized session, I hope that we would be able to diagnose MASLD with confidence. We would be able to stratify patients by using non-invasive tests, and I will concentrate on the FIB-4 score. We should be able to refer to secondary care appropriately and timely, to offer lifestyle advice to all, and to control features of metabolic syndrome intensively. And if we have a bit more time, we touch on who to reassess and refer or re-refer, and a little bit about the future, just to be aware of the new therapeutic options, because there will be expensive drugs that are on the horizon, not here yet, but the first drug was FDA approved in March 2024. So introduction, I'll cover the name change from NAFLD to MASLD, and why I think it's important and it's a good idea to have a proper name. Can't really talk about this without giving an idea of the scale of the problem and the epidemiology. And also NAFLD, MASLD's got a new name, but it's also hopefully got a new family of this cardiorenal metabolic axis, and it sits in the metabolic bit together with pancreatic islet cell dysfunction. We'll talk about diagnosis, and I got a brief case study for you to make it a little bit more clinical, how we risk stratify our patients. That's probably the most important part of the talk. We can't really be in Lanarkshire and not talk about interactions with alcohol, and how we manage NAFLD MASLD in 2024, and what the future holds for us on the horizon. So let's talk a little bit about the name change, and this came about very recently, just at the end of 2023, and it was a Delphi process where multiple liver disease societies across the world went through this very extensive consensus finding process and came up with a name change, but also with the new guidelines. So at the moment, this is a hot topic in hepatology, and you would probably see at least some of our letters where we use the word MASLD rather than NAFLD. It took my secretary a wee while to learn how to spell MASLD. It was MUZZLED, but it's not that. It's MASLD, metabolic dysfunction associated steatotic liver disease, or metabolic dysfunction associated steatohepatitis. So we now got MASLD and MASH. And this graph here, this is steatotic liver disease at the top as a whole, and basically in the UK, this would be presence of fatty liver or steatosis on the ultrasound scan. And then we'll look into the causes for this. So if we start from right to left, obviously alcohol is one of the commonest causes of fatty liver. And this is alcohol-related liver disease. And then on the other side is the metabolic dysfunction associated steatotic liver disease, or MASLD. The positive changes people felt that this brought is that it tells you what it is rather than what it isn't. So this is a liver disease associated metabolic syndrome. It's a positive definition rather than saying what it's not. And also, crucially, you can have a group here that allows you to have patients who have MASLD, so liver disease due to metabolic syndrome, but also alcohol. So it's called MET-ALD, and it could be MASLD predominant or it could be ALD predominant. And in a lot of our patients, this is the combination that we see: obesity and alcohol, and both need to be addressed. Also, this group of people have been excluded from clinical trials because alcohol ruled them out of NAFLD trials and metabolic syndrome ruled them out of ALD trials. But now they're a separate group and they could be included in research. And there are many other benefits to changing the name. I think that the word fatty, a lot of people didn't like calling people fatty, so it's now called steatotic liver disease. And hopefully this reduces the stigma and allows more open conversations with the patients, clinicians, and policymakers as well. So this is a global problem. The global prevalence of MASLD is rising, and it's closely linked to increasing type 2 diabetes and obesity rates. And the map of the world is shown here, and the prevalence ranges from 25 to 40% of population, and the global rates of MASLD are rising with time. I think current, very recent data from the United States suggests that in that country, it's about 40% of population will have MASLD or NAFLD. We shouldn't be complacent seeing us here in the Western Europe in green, because Scotland is actually a third place after United States of America and Kuwait in terms of prevalence of overweight and obesity. This data is now about 6 years old. So up to 70% of population is classed as overweight and obese. So this is just a brief reminder for me to tell you that the MASLD diagnosis and care is variable in the United Kingdom and also worldwide. The majority of the patients in the UK remain undiagnosed, and there is variation in delivery of care in the UK between different hospitals England, Wales, and Scotland participated in this audit, and the reference is at the bottom. And this triggered the publication of a UK-wide quality standards for the management of MASLD, jointly from the British Association for the Study of the Liver and British Society of Gastroenterology, and the reference is given here. So there is a lot of work to be done to standardize care and to bring it up to a gold standard that we should all be striving for. And that's a separate topic of probably another talk. This picture here, just to remind me to tell you that we are all familiar with the cardiometabolic renal interconnections in the body, very complex physiology out with the scope of this presentation. But for example, when somebody is diagnosed with type 2 diabetes, we are all very comfortable thinking about proteinuria, microalbuminuria, thinking about the kidneys and calculating the cardiovascular risk, and also a lot of medications that's used. In prime example would be GLP-1 receptor agonists, act on all three components of this axis. So this is taken from a very recent review of the CRM axis, but as you can see, the liver is not documented here, sadly, but I think this will also change, hopefully in the next few years, because MASLD is a systemic disease and it is a hepatic manifestation of the metabolic syndrome. And if you look at patients with MASLD, the prevalence and incidence of chronic kidney disease is higher among patients with advanced fibrosis. There is also a very strong association between MASLD and atherosclerotic heart disease, heart failure, and arrhythmias, particularly AF, and a very tight relationship with type 2 diabetes and obesity. So we would recommend that patients with MASLD should be screened for type 2 diabetes. The prevalence is up to 20%. And also the presence of type 2 diabetes increases the risk of advanced fibrosis and cirrhosis, or severe liver disease. And I think in the future, we see here already that medications like GLP-1 receptor agonists, tirzepatide, act on all components of the axis, and this is where I think the new developments will come to improve not only single organ health, but the health of the whole body, and prolong survival and improve quality of life. So this, I thought, was a very nice paper from last year from Journal of Hepatology, and they looked at adults aged over 50 and over with type 2 diabetes, and they stratified them by obesity status. So if you think about all the diabetic patients you have on your books, if they are obese, and most people are, then the prevalence of NAFLD is here 72.6%. Non-obese, it's less. And prevalence of advanced fibrosis, thankfully, is less, about 18% in obese patients, less in the non-obese patients. And cirrhosis, importantly, 7.5% in obese patients and 3.4% in non-obese. So another way to have a look at this is that we can divide the patients into three groups, okay? And the most prevalent group of patients with NAFLD or MASLD will be the diabetics, okay? So thankfully, group 1 here, they have NAFLD, they have fatty liver, but they don't have advanced fibrosis or cirrhosis. These patients, in vast majority, And the mainstay of their management is management of metabolic syndrome, controlling diabetes, cardiovascular risk, hyperlipidemia, weight, etc. People here in the cirrhotic group, these are the patients that we are desperate to identify and meet in our clinics and secondary care, because we want to diagnose cirrhosis earlier than we do currently. These people need to enter into the hepatoma surveillance program. We need to think about varicose bleeding prophylaxis and an intensive management of their comorbidities. We need to think about decompensations and early referral to liver transplantation if appropriate. And these people have a high risk of mortality from liver-related events, but still cardiovascular risk remains high even in patients with cirrhosis. And then this group in the middle here, for a long time, advanced fibrosis, we were not quite sure where they belong, whether they belong in primary care, secondary care, does it depend on their age, comorbidities, functional status. But the new therapeutic options that are coming along are targeting this group. Maybe not advanced fibrosis, but mild fibrosis, which is reversible. So the hope is that resolution of MASH, so steatohepatitis, inflammation, and mild fibrosis would shift this group into the good prognostic category group. And I think their management will be more complex in the next few years. So just to give us a bit of break from epidemiology and graphs, I've put in a case study, and this is the commonest LFT abnormality that we see in patients with NAFLD or MASLD. So mildly elevated ALT, less than 150, some people say less than 200, usually between 50 and 120, okay? So we've got a 40-year-old male patient who's a lawyer, and he had routine bloods because he was having recurrent tonsillitis. And LFTs were checked as a panel of routine bloods, and all his LFTs were normal, but his ALT was abnormal, 65. His past medical history, gout, couple of attacks of gout, not on any regular medications, only occasional alcohol. And there is family history of type 2 diabetes, hypertension in his father and maternal grandmother. BMI is obese, 32. And the GP quite reasonably decided to repeat the LFTs in 6 weeks' time when the patient was well, because viral illness can cause ALT elevation, and ALT came back at 99, and the rest of the blood tests were within normal limits as prior. So here, I think it is important to say that it's important to do a chronic liver screen panel, or liver screen, as we call it, and more often than not, it's now an order set on the electronic requesting system that you can just click liver screen and all the blood tests will be collected. So his chronic liver disease screen was negative, and I would say that for me the important differentials here, we don't want to miss chronic viral hepatitis, because there are still cases of hepatitis B infection that we diagnose, and hepatitis C. And obviously with the infected blood history, with rising prevalence at the moment of hepatitis B in young people who are in Scotland as well, it would be disastrous to miss a chronic viral hepatitis. It's imminently treatable. Wilson's disease, very rare. I personally only have one patient with Wilson's disease that I look after, but in a young person, it's important to do ceruloplasmin. Autoimmune hepatitis, we always worry about it, but with very mild ALT, it's very unlikely. But the liver screen blood test will help us. And then I think here, it's worth saying that most people will ask for an abdominal ultrasound scan, and it will show fatty infiltration of the liver, otherwise it would be normal. And the diagnostic yield for abdominal ultrasound scan in patients under 65 with no symptoms and only abnormal liver enzymes is extremely low, and you would be okay not to do an ultrasound. But if you're referring a person to secondary care, then an ultrasound would be useful. So this is something to think about in terms of how we utilize ultrasound resources. So here we have fatty liver on the ultrasound report. One of the questions when I was preparing for this talk was, what do we do? And we follow this algorithm. We've got fatty liver on the ultrasound. Does the patient meet any of the cardiometabolic criteria? And these are the adult cardiometabolic criteria here. So all the obvious ones that you would know. So increased BMI, evidence of diabetes or impaired fasting glucose, hypertension, dyslipidemia. And if the answer is yes to at least one of them, so our patient here from the previous slide was obese, so tick that box already. Then you say, are there any other causes of steatosis? And this is alcohol. You would want to ask them about alcohol. So no alcohol, it's MASLD. Okay, and if they drink alcohol, it's either MET ALD, so both, or ALD, depending on how much alcohol they drink. Just put the slide in here very briefly. These are all the medications that can cause steatosis. I have to look this up every now and then, and this is just here for the reference for future use. Obviously, steroids, tamoxifen, and amiodarone, and chemotherapy agents. Just move on from this slide. So, for me, this is the most important part of the talk. It's how to risk stratify patients who have MASLD. And at the moment, we do this by doing a fibrosis assessment because prognosis is linked to the stage of fibrosis. That was a key finding a few years back. Lots of evidence in the literature. Don't have time to show today, but it's the fibrosis stage that drives prognosis in NAFLD, and therefore it is extremely important to know what's the fibrosis stage of the patient. So we have a healthy liver we're all born with here on the left-hand side. Then the liver becomes fatty or steatotic, and then the inflammation secondary to steatosis drives the fibrosis. And the fibrosis is divided into metavir stages from F0 to no fibrosis, it's no fibrosis, F0, to F4, which is cirrhosis. And significant fibrosis is F2, F3, and F4 is cirrhosis. So F0 and F1, you can see the kind of the prognosis is good. And then there's decompensated cirrhosis and hepatocellular carcinoma. So the aim in primary care is to rule out advanced fibrosis because you are dealing with low prevalence population, overall general population. And you can use FIB4 or NAFLD fibrosis score, and there are online calculators. Personally, I prefer FIB4 because it is objective. It is only your age, ALT, AST, and platelet count. You don't need to worry about the BMI or any, if you don't know about insulin resistance. Very easy to do FIB4. It's The caveat here is that FIB4 has low accuracy in very young patients under 35, and I think they should be referred to secondary care. And what we're doing now is we'll do a FibroScan and we'll give advice tailored to the patient. If FIB4 is less than 1.3, it has a negative predictive value of 99% to rule out advanced fibrosis. This is really good news for you, the patient, and they can stay in primary care. Use the age-adjusted cutoff in patients older than 65. The cutoff is higher, it's 2. So anything less than 2 is fine in over 65s. And then really wanted to show you a couple of slides just to kind of emphasize the point that fibrosis determines survival. So if we look at FIB4 here at the bottom left, FIB4 less than 1.3 is in red line. You can see that survival is excellent, up to 14 years here, the data. And as you move up fibrosis stages, obviously the survival is less, and FIB4 is over 2.67. These will be people here with cirrhosis of the liver. Their survival is poor. And whether you characterize fibrosis by FIB4, here we've got NAFLD fibrosis score at the bottom next to it, FibroScan, liver stiffness, or biopsy, the results are very similar. And the fibrosis stage also predicts liver-related outcomes, and that wouldn't come as a surprise to you. So if you have F0 to F2 fibrosis, your chance of hepatic decompensation or liver cancer is very, very low. Your risk of death is also low, it's not negligible, and this is extrahepatic cancer. It's more common in people with MASLD, and therefore people should be encouraged to participate in the bowel, breast, cervical, etc. cancer screening programs. So this, we all, I think, like a flow chart. It kind of gives us guidance and reassurance we're doing the right thing. This is taken from the BSG website. It's freely available. Obviously, I'm happy for my slides to be shared and available. And it gives a very good summary of what to do. So if people have abnormal liver enzymes, so like the case I presented, mild ALT abnormality, you would do a liver screen and ultrasound, you can diagnose NAFLD. If they've got an ultrasound report back saying there is fatty liver and you think it's NAFLD, and more now we're looking for people with high risk pathology, so obesity, type 2 diabetes, metabolic syndrome. NAFLD is very prevalent, and diagnosis can come this way. So the key here and the center stage is assess for fibrosis. So NAFLD fibrosis score or FIB4. Okay. If FIB4 is less than 1.3, and the star here is to remind us about age-adjusted cutoffs, people are in a low-risk group, and you would monitor them. So the BSG says consider monitoring every 2 years. I wouldn't spend too much time and get too stressed about how these people are monitored, because hopefully we'll have a national MASLD pathway and it will give clear guidance as to who's monitored, how often, and where. But essentially, in a young patient with lots of metabolic risk factors, you would do more intensive monitoring. And if there's maybe 1 or 2 metabolic risk factors, you can maybe leave it 3 to 5 years. But that's, nobody really knows. It's a consensus decision how to monitor. But obviously would need to monitor because the diabetes and metabolic syndrome rarely go away. If the NAFLD fibrosis score of FIB4 is indeterminate, so between 1.3 and 3.25, this is intermediate risk, and what we would suggest is you would refer to secondary care at the moment for a second sequential assessment, and at the current time, this is with a FibroScan, and it's only available in the hospital. In some places, it's available in the community, and other places, you can do an ELF blood test, which is works. It's part of the algorithm here as well. But here in Lanarkshire, refer for FibroScan. And obviously, if FIB4 is very high, refer high-risk patients, refer to secondary care. We would do a FibroScan and we would follow these patients up. People often ask, and we had a couple of emails also to our service about screening for advanced fibrosis. And this is something that hepatologists are very keen to do, because what we see nowadays on the wards in patients, 70% of patients with liver cirrhosis present with decompensation, and they have never been diagnosed with cirrhosis. They have no idea that they have cirrhosis of the liver. So not only do they have cirrhosis of the liver, they're given this diagnosis at the time where they're already decompensated and occasionally already have hepatocellular carcinoma. And this is a disaster in hepatology world. This is probably the biggest disaster, is diagnosing HDC at first presentation. And it happens not infrequently. So we want to identify people with cirrhosis early so that we can intervene. And the high-risk groups defined here, this is from the American guidelines that recommend screening. Not all guidelines recommend screening. So in the interest of fairness, I would say this is a contentious issue. There's advocates and people who are against it. But you can see that people with type 2 diabetes, prevalence of advanced fibrosis up to 20%, medically complicated obesity, so obesity with other features of metabolic syndrome, again, high prevalence of advanced fibrosis, NAFLD and alcohol, very deadly combination, high prevalence of advanced fibrosis. And interestingly, less references here, but there's emerging data that first-degree relatives of a patient with cirrhosis due to NAFLD also at an increased risk. So something to ponder and think about for all of us. I can't really give this talk looking after the population of people that we all look after without stressing that there is very synergistic interaction between alcohol consumption and metabolic syndrome. So here we have, apologies if the slide is blurry, in red is diabetes, in blue, no diabetes. So no diabetes, and if you drink more and more and more, then you have more and more chances of developing severe liver disease. That's obviously, we all know that. If you're diabetic and you don't drink, your chances of developing severe liver disease are higher because of the MASLD. But if you are diabetic and you drink to excess, really, your risks are high of developing cirrhosis and complications very quickly at an early age. This alcohol units is here is in grams, 50, 100, and 150. 1 unit of alcohol is 8 grams. And I was very wanted to share this with you. This is hot off the press 2024 publication that actually tells us that screening for fibrosis promotes lifestyle changes. Okay, so people were had a FibroScan, and then they were assessed 1 week post screening, 6 months, and 2 years. So quite long follow up here. And If people were drinkers, they were screened because they're high risk, and they actually decreased their alcohol intake. And people with metabolic liver disease, improved diet, increased exercise, and some of them achieved weight loss after 6 months. So the green bars are the people that achieved change. The numbers are not high, but every person, every percent is a win overall. So screening for liver disease actually makes a difference by educating the patients and improving their health. This is also a key slide for me. This is what patients with MASLD of all fibrosis stages, that's what the mortality is from. So number one is cardiovascular disease. Number two is non-liver cancer. And cirrhosis and its complications and liver cancer is actually, the numbers are small. As the disease progresses to more advanced fibrosis and cirrhosis, then liver-related complications, of course, do occur, but still the commonest causes of death is cardiovascular disease and non-liver cancer. And this brings me into management of MASLD. So this is from the American Heart Association, their Life's Essential 8. I thought that looked quite nice, a nice pictogram. So diet, Mediterranean style diet, we recommend avoiding refined ultra processed foods, and fructose, and coffee is protective and reduces your risk of liver cancer. So that's the dietary advice in a nutshell. Physical activity tailored to the patient. It doesn't really matter if it's aerobic, anaerobic, any physical activity. And then management of diabetes, management of weight. So Lanarkshire Weight Management Services, way to go, or everybody should be advised to join, controlling cholesterol, managing blood pressure, advice on stopping smoking, and healthy sleep also improves your metabolic syndrome. So in the last 5 minutes, if I may, I'm just going to touch on the new developments in service delivery and also in clinical management. So there will be a national Pan-Scotland pathway for MASLD via the National Centre for Sustainable Delivery. It will unify all our efforts and approaches. It will give us numbers that for FibroScan that vary at the moment from guideline to guideline, but the FIB4 will be there, and the cutoffs will stay the same as in my presentation. Also, we're working very hard on introduction of intelligent liver function testing, or ILIFT, service in NHS Lanarkshire. This service is available in Tayside and the NHS 5. And essentially, this will hopefully make GP primary care life much easier, because it will combine etiological investigation, so chronic liver disease screen, and fibrosis assessment via FIB4 to produce guidance for your teams as to the diagnosis and the management. So you just need to request ILFTs, and you'll get an advice as to what to do with the patient, whether to keep them in primary care, whether to refer. And then the new drugs are coming. They were going to be very expensive, about 50,000 a year for some of the new drugs. And therefore, we will likely need metabolic MDTs, including diabetologists, cardiologists, potentially dietitians, health psychologists. And the drugs target steatohepatitis and fibrosis, but also improve metabolic syndrome, so weight loss, hemoglobin A1C, and lipid profile. And this medication called resmetirom, we all have to learn how to say it, is has the first medication that's been approved by FDA. It's not approved in the UK as yet. It's the first treatment for patients with liver scarring due to fatty liver disease. It's an oral tablets, it's liver directed, and it's a thyroid hormone receptor beta selective agonist. This was a phase 3 trial published in the New England Journal of Medicine. 52 weeks of treatment. You can see that it resolves NASH, so steatohepatitis inflammation, without worsening fibrosis, and it improves fibrosis. And the numbers of percentages are not great, but this is really a revolutionary publication in the liver field. Also improves LDL cholesterol, but has no effect on patients' weight. And maybe some people will start asking you about, is this available? So it's worth to be aware of at least what it is. And then the future, I think, is with GLP-1 access. Okay, we already have GLP-1 analogs if we can get them. But now tirzepatide is the twin creatine therapy, so acts on GLP-1 and GIP, has a multitude of beneficial effects on all organ systems and the liver. And this was presented at the meeting and published just this month in New England Journal of Medicine. It also improves MASH and fibrosis, so works on the whole body, improving the metabolic syndrome. Obviously, long-term follow-up data is not available because these are all very new medications, but I think this is probably where the future is going to be. And NICE already recommended tirzepatide for weight loss and increasing access in the NHS. So this is just from 5th of June. So I hope I'm on time. Just a few take-home messages. Sorry, there's a lot of writing on this slide, but we'll just go through them one by one. So MASLD, I hope I've convinced you this is the most prevalent liver condition worldwide and is very tightly linked with obesity and type 2 diabetes. Patients with MASLD have both increased liver-related and cardiovascular morbidity and mortality, and most excess deaths occur through cardiovascular disease. And this is really where primary care, I'm hoping, we rely on your expertise in managing the cardiovascular risks. Accurate staging of liver disease is important for risk stratification, and this is currently achieved through sequential non-invasive testing in the majority of patients, so FIB4, FIB4, and more FIB4. Lifestyle modification and bariatric surgery where appropriate, alongside aggressive cardiovascular risk reduction forms the mainstays of treatment. And there is evidence that if there is a multidisciplinary approach, or at least if there is communication, working together between primary, secondary care, allied health professionals, that this improves outcomes for patients. And the therapeutic landscape is developing very rapidly, and several potentially disease-modifying drugs are now in phase 3 clinical trials, and one drug has already been through the FDA rapid approval process, so there will be more to come. And I'm happy to take questions. I'm happy to take questions via email. Please get in touch. If I can be of any help, just let me know. Thank you very much.
Thank you very much. That was a fantastic presentation. I learned a lot from that. I don't see any questions in the chat. Does anyone want to raise their hand and ask a question just now? Yep. So I'll just take them in order. So first of all, we've got Susan.
Hiya, thanks. I thought that was a really good presentation. I've got a couple of things that have cropped up. The alcohol intake, I'm just a bit confused. Does your FIB4 score correlate just to non-alcoholic fatty liver disease, or can you use that in alcohol-related liver disease? And what would your cutoff be for the mixed, what kind of unit, because I didn't understand that slide. What is your cutoff for alcoholic liver disease and non-alcoholic? That's one of my questions. The other one was you mentioned liver screen panel on order comms, which we don't have, which would be really, really useful, because otherwise you've got to go and tick them all. My other question I wanted to ask was about ferritin, and is that a predictor? Because often we're seeing fatty liver in people who've got normal LFTs. So is ferritin something we should be looking at? And waiting times and getting knocked back for fibroscans. I've had several patients that I've referred with FIB4 scores that I thought were indicative to get a fibroscan, and they've been knocked back, and I've been told to address their lifestyle before referring them back. So sorry, I know that's a lot of questions, but yeah.
Yeah, thank you, Susan. So FIB4, just to give a bit of a background, and kind of non-invasive assessment of liver disease is a separate topic. I'll be very happy to talk again, but it came from the hepatitis C world. Okay, so it's used in hepatitis C in just exactly the same way it's used now in NAFLD, ALD. So doesn't matter what liver disease etiology, use FIB4 because a low score is very reassuring. If it's alcohol, Hep C, ALD, or we have patients with combination of the three, okay? Very unusual to have a normal FIB4 in those patients, but possible, and a normal score is very reassuring. So same cutoffs, all etiologies. Liver screen, the order comms obviously has changed recently. It has hopefully allow us to do the ILFTs because bloods have to be requested electronically from primary care for us to do the ILFTs. So I think something that we can work on in hospital and secondary care, we just click liver screen, but that's just us asking the biochemistry who organize the testing to put it together. So order sets definitely possible. Definitely helpful, and I know in other health boards they are used. Ferritin, again, this is another whole topic. There's just been a recent publication about review of metabolic syndrome-associated hyperferritinemia, what it is, how to diagnose it, different stages. And yes, there is evidence that severe hyperferritinemia indicates worse prognosis in NAFLD. Yes. What else? Knockback from FibroScan. So the EASL, the European guidelines that were published this month in the kind of indeterminate risk between 1.3 and 2.67, the guidelines say you can either refer for a FibroScan or you can do intensive control of metabolic syndrome. So A or B guidelines support it. So it very much depends on the resources, isn't it? Availability, where you're working. So yes, both options I think are reasonable, and obviously if the score comes down, then that's good. But I think even speaking to the patient and telling them what you're doing, as I've shown a little bit of data, that hopefully that will promote some improved behavior and better control.
Thank you. Has that answered all your questions, Susan? Have you got anything more? No, good. So next we've got Malcolm Riddle. Do you want to come in?
Yes, yeah, very interesting talk. I was just wanting a bit of clarification about diagnosis. So as I said, as part of our liver screen, we would normally do an ultrasound, but you seem to suggest that that wasn't necessary. But my understanding was we need the ultrasound to diagnose fatty liver. Is that incorrect, or?
So that's, yes, so that's a relatively new thing. And I think it will be embedded in clinical. So if you look at the Lothian guidelines for GPs on Ref Help, that's where I copied it word for word. So in people less than 65 who are asymptomatic, you don't need to do an ultrasound. It will take a wee while for all of us to be comfortable with it. I'm not suggesting that we should enforce it. It's just there for you to think about.
So then if we had an otherwise negative liver screen, but these mildly abnormal LFTs, would we then presume that they've got MASLD or
So if they have metabolic risk factors, yes.
okay.
If they've got type 2 diabetes and they are obese, 90 to 100% of them will have fatty liver on ultrasound.
And then in that case, with patients with diabetes, should we be considering doing a FIB4 score on them anyway, regardless of what their LFTs are? Should we be doing that as part of a routine review?
Thank you for asking this question. Yes, and yes. The diabetic guidelines that I'm less familiar with, but the ones I've seen advocate for FIB4 in all diabetic clinic. So in all patients with type 2 diabetes. And in some places, when you request your diabetic bloods on an order set, the FIB4 is automatically calculated. We're not there yet. But yes, these are the people where there is a lot of NAFLD. Well, all of them will have NAFLD more or less. But more importantly, there will be people there with cirrhosis that in 5 years' time will come in with ascites. And we're controlling the metabolic syndrome well. And so what I am seeing, I don't have any data. There is some data emerging that the decompensations in NAFLD now happening in the people in late 70s and 80s because they've been on a statin, they've been on an ACE inhibitor, metformin, and they've survived a couple of mini strokes and a heart attack, but they present with ascites when they're 79. Not uncommon.
Thank you very much. Any other questions? I'm just mindful that we're coming up towards our time. So the ILFTs, I believe that they are coming to Lanarkshire, but I don't know that we've got them in primary care just yet, so I'm not exactly sure what the timescale is for that. And also we're in a bit of a difficult situation at the moment where some of our practices can order an order comms, but some practices are just having to write out by hand still. The consensus meeting, do you know when that we're likely to get the information from that pathway?
For the CFSD pathway
Yes.
for NAFLD or MASLD, I don't know the timescales, but I know it's in development, and obviously they go through secondary primary care interface kind of representation, so that primary care obviously has to be 100% involved and on board with any pathways that are developed. The ILFTs, we've developed we've adopted the algorithm from Tayside, and at the moment it needs to be programmed into the lab system, and we've just got funding from the BBV MCN who are interested in detecting obviously hepatitis C, the remnants hopefully that are still in the community. They funded for the company to program the lab system. All the GP bloods go to Wishaw on a single track system. And once that's in place and the internal testing is done, then we would be looking to pilot it in maybe one GP cluster or somewhere where we can have a very close oversight of it and see how it is performing in real life before rolling out pan Lanarkshire.
Fantastic. That would be really, really welcome. And obviously, we're waiting for this information to come out to us. Is there anywhere that you would direct us in the meantime if we want further information, for example, about high ferritin? Or, I mean, is there anywhere, any local guidelines or national guidelines you would direct us to?
So I think there were some guidelines on the Royal College of GP website. There is good information on the British Society of Gastroenterology. They've come up with that flow chart that I showed you, and they've also come up with the key quality performance indicators as to how people with MASLD should be looked after. So if we're thinking about service development, that's certainly something we should look at. The European guidelines, it's EASL, European Association for the Study of the Liver, are in press, but are available already online. Lots and lots of nice flow charts. If you are a visual kind of learner, I would recommend them about diagnosis, risk stratification, and also a really nice summary about management. What to advise about diet, what to advise about weight loss, really nicely presented. Happy again. We can share links or PDFs or whatever people want to. If I can be of any help, just let me know.
Thank you so much. Well, that's us nearly to time, so I just want to especially thank our speaker for coming to speak to us today, and to everyone for attending. Into the chat, I'll just put some feedback, if you don't mind giving us some feedback, and also the link to the website where this video will be uploaded is in the original email where you got this invitation, and that will be uploaded in 2 to 3 weeks' time. So thank you, everyone. And Natasha, any final comments before we go? Anything that
think about your diabetic clinics, A&P, nurse practitioners. People are there undiagnosed with cirrhosis. Do the FIB4.
that's the main takeaway.
That's the main thing. Just do the FIB4. Remember, going back to Malcolm's point, there are lots and lots of many people with cirrhosis that I see every day who have normal LFTs. Liver function tests are not liver function tests. That's another talk. They could be normal, but people have cirrhosis. So do the FIB4. It will come out in the wash. The other worrying sign is low platelets. So don't refer to hematology if you think they've got autoimmune thrombocytopenia, but low platelets is a big warning sign for me. That means they've got splenomegaly and they've got cirrhosis 9 times out of 10. Okay, there are other causes of low platelets, but in Lanarkshire, I think it's cirrhosis until proven otherwise.
That's really good to know. Thank you so much. Well, everybody, thank you so much for attending, and I'll just wish you a good afternoon. That's us finished the time. Thank you very much, and thanks again, especially to our speaker. Thanks, Natasha.
Thank you. Thank you.
Bye-bye.